fantastic introduction lectures here to see how personalization is transforming health. And the more we engage with it, the more likely it is we're going to succeed in living healthier lives. So thank you to the three ladies that spoke before me. And I took note of Judith's comment that I was the token male today. So happy to represent my sex. So I just want to give a little bit of background as to who we are. And Judith led me in. She didn't tell me she was going to say that as an introduction. So this is going to be a little bit different as we move along. 30 years ago, I met a doctor, a little bit coincidentally, who told me that healthcare was changing. It would all be personalized. We'd understand our underlying biology, our immunology. He talked to, even then, in the early 90s, he spoke about gut health. He spoke about food allergies. He spoke about hormonal health. This is a small clinic in Copenhagen, in the back streets of Copenhagen, not the big hospitals, not the leading physicians, not the leading researchers. And something twigged in me that this might be an interesting area to look at. So over the past 30 years, I've built a group of companies together with Anne-Catherine that spread across this personalization approach from Nordic Laboratories, where we have a whole array of functional tests, to Nordic clinics. At one stage, we had 7 of them before COVID. VMS was the first online platform. Then we brought in genetics. Very nice to hear Anna fronting the need to do genetic testing. Disruptive, I invested in because I didn't invest in Aura, and that was an error. So I invested in a company called Disruptive, and we have developed subdermal chips that go under the skin, and a little bit like the ladies were talking about, how we can monitor longitudinal data sets will become the future of health. It's not about the here and now, it's about what happens going forward. So if we had a continual system that updated and showed us warning signs before they happened, before incidences happened, this would surely be a good thing for our overall health. So I have a chip in my arm and a chip in my hand, and we're trying to build that technology out. MedCheck is pharmacogenomics, and for the doctors in the audience, though this is one of the weirdest things for me. We're in the 2020s. We have a lot of data around pharmacogenomics. Why on earth are we not using PGX before prescribing a drug? There are drug-gene interactions that will either have a positive, neutral, or negative impact. We know this, but we don't do it. So this disturbs me. We have knowledge that we don't employ. Resistomap, the biggest single threat to humanity, even though global warming seems to be accelerating, is not global warming. It is the end of the functionality of antibiotics. We're in a post-antibiotic era, and we have to curtail the use of them. So we invested in a company in Finland that measures this in the environment. The EU is doing a great job at promoting this across the countries. UK is the biggest and most focused area in the world for antibiotic resistance measuring, but we have to accelerate the thinking. ThermoCheck, you'll hear a little bit about in a minute from Emma. Fufu is functional foods because I'm an organic food. I'm so focused that everything we should be eating is organic. We should be promoting organic farming. We should support organic farmers, and we should pay the price. We should be willing to pay a premium for our health. And then most recently, we moved into pet health. When I come to Ireland, I like to put this picture up because I just got my Irish passport a year ago, so I'm very happy. And this is my old granddad. I didn't know him very long. He died a few weeks after this picture. And when we talk about the future of health, where we're going, I think it's always important to look back at where we came from. So, a slightly morbid task. I'm going to ask you to close your eyes. Not quite yet, because the next question comes up. Close your eyes. And now imagine you're lying in bed, surrounded by your loved ones, at the end of your life. Right? Just do that. Just close your eyes. And then I'm going to ask you to think or to now, when I go through the next slide, you can open again. How many of you, how old were you when you passed away? 70? 80? 90? One person? 100? Are you going to live forever? Older? Everyone? Okay. That wasn't the answers I was expecting. Okay. When I close my eyes, I'm not 120, and I don't think we're going to live that long. The risk of it is that we will spend many years in poor health. Women more than men. Maybe it's because you live a little bit longer. But actually, in the UK, the women go in, at the end of health span is around 61 years. And their average age is 82, 83. So 25% of women's lives are in poor health. So as we heard earlier, we need to extend health span. Now, my first question didn't work out the way I wanted it to, so I'm not sure this one's going to work out that way either. But anyway, let's try. Now we're going to 21, 25, and we're 120 years old. We've made it. We're still alive. What would we be saying to our 20-year-old self? Right? I use this question mainly to try and trigger a reaction into, if we're 100 years ahead and we look back, we're going to laugh at some of the things that we didn't do, right? Why didn't we employ that? Why didn't we do this? We had all this knowledge. So, Bill Clinton said in 2000, we're here to celebrate the completion of the first survey of the entire human genome. Not quite right, Bill, was it? Wasn't quite. It was 97%, and now we probably think it's only 95%. But anyway, close to. And without a doubt, this is the most important, most wondrous map ever produced by humankind. So the leader of the free world tells us this is the best map we've ever created. Right? So that must be an incentive. We must be following. Now, the only person that I have heard actually promote genetic testing is Anna, as she sat here. How many of you have done your genetic tests? Okay, more than I thought would be. That's good. This is your 125-year-old saying to your 20-year-old self, right? Have you done your test? Have you done it? Because you should do it. What did you do with that information? Have you done anything? Have you made changes? Probably not, is the case in most people. So, now, we know that Bill Clinton said this is the wondrous map. We know our 125-year-old would say to us, have you done your genetics? So do we have any evidence for doing our genetics even before we're born? Well, we can't do that because we haven't yet worked a way to get in the womb. But we can do it in the mother and the father. And we heard earlier, again, sperm quality as an example. Very good point. Men do tend to say, nothing wrong with me, as long as you can do the 10-second trick and you've done your job. But health isn't just about the individual, it's about society. And we have a social and moral responsibility to be well if we can. So here's the problem statement. Preterm births across the world continue to rise. So how can we mitigate it? Look at this. This is Ireland. Can we see that? All right. Oh, it actually comes out quite well. So in the last 10 years between 2010 and 2020, we increased from 4.5% to 7% preterm births. That's pretty odd, isn't it? How does that go? I haven't looked at the cause, but there's something wrong in the state of Ireland, as there is in the rest of the world. There's not much data on Ireland, to be fair, so I have to go and look at the UK. The UK take it very seriously. Both houses of parliament have missions around preterm birth. So the first, this is from the House of Commons The first 1,000 days of life from conception to age 2 is a critical phase during which the foundations of a child's development are laid. If a child's body and brain develop well, then their life chances are improved. Exposure to stresses or adversity during this period can result in a child's development falling behind their peers. That's in the House of Commons. This is in the House of Lords. And just go back to that. There's a special inquiry committee to prevent preterm birth. This is at governmental level. So if there's any politicians from Ireland here, you need to think of that for here as well. This is the problem. This is the Food Foundation in the UK. And look at, on the right-hand side, height of 5-year-olds have been falling since 2013. Do you know when the last time that happened? The 13th century. So what is going on? Obesity rates going up. Type 2 diabetes going up. And look on the left. Babies born today will enjoy 1 year less good health than babies born a decade ago. So your 125-year-old self is saying, don't do this to me, get it sorted. There are significant financial costs surrounding preterm births, both for the interventions in the short term and the longer-term financial impacts on health services, education services, and the family involved in caring for a baby born preterm, says that report in the House of Lords. In November, so this is now 2023, this is a statement, 2023, but it looked back at 2017 that there was a strategy in the United Kingdom to reduce preterm birth rate from the about 8% to 6%, a modest reduction, but at least a goal. The report says little to no progress has been made on reducing rate of preterm birth in the 6 years. That study was from 2017 to 2025. We're in 2025 now, so let's look at what's happened. In the last 3 years, the total number of UK births has fallen. That's another problem. But the number of preterm birth has increased. So the strategy employed at governmental level failed. The cost of preterm birth in the United Kingdom is around £3.4 billion per annum. That's an average cost of £71,500 per birth. What if we could change that? What if we could change it? That upward trend. Preterm births are driven by a range of factors. One is the increasing maternal age. We don't fully understand that, but it seems to be obvious in some ways. There's also the higher rates of multiple pregnancies due to IVF and that type of thing. But other factors are infections, chronic conditions the mother suffers with, lifestyle factors, lower socioeconomic status. This is a very big problem, and it's just a very nice paper was published a few months ago from the University of Bristol that showed this very clearly, that Caucasians have a lower preterm birth rate than to other minorities. Low education level. This is another big impact. So short and long term. This is what we call transgenerational health, 1,000 days and long-term impact. A mother may be at risk for gestational diabetes, preeclampsia, and miscarriage. That's her risks. And additionally, maybe postpartum depression. The baby's risk is a high or low birth weight, premature and stressed. And the combined factors for both is a decreased health resilience, increased risk of cancers, non-communicable diseases, asthma, neurodevelopmental disorders, and in the females, early menopause. This is associated with gestational periods. Preterm, this is, again, remember this is the UK, but it sort of flexes across Europe pretty well. The average age of the mother might be impacting that. Increased IVF, multifactorial, other impact factors. But what's the overall fundamental of a preterm birth is that cardio problems, blood glucose problems, so the increase in diabetes risk, mental health disorders, ADHD, and other. And the key bit is that it goes into subsequent generations. If you're preterm, the risk of a preterm baby in the next generation in your child is higher, significantly higher. Small for gestational age. 2.6% in 2020 increased to 2.9% in 2021. Why? Maybe COVID, I don't know. But the short-term impact of a child small for gestational age is lower verbal, spatial, and numerical test scores in childhood. Long-term is dyslipidemia, hypertension, unfavorable body fat distribution, non-insulin dependent diabetes. Interestingly enough, when I went to the Philippines and gave this presentation, the Philippines have 15% preterm birth rate and a very, very high level of small for gestational age. It's a very major problem in their development. Large for gestational age, 23%. 23% of babies born are too large. And the impact is, for the mother, is maternal hyperglycemia, the long-term predictor of obesity for the child, higher risk of hypertension, type 2 diabetes, cardiovascular disease, and certain cancers. So it's not good to be born too big. You know, all these grandmothers say, well, my grandson was huge. It's not a good thing. Needs to be normal weight, please. Gestational diabetes, it's a problem because the data is not that clear, but somewhere between 5 and 20% of all pregnancies have result in gestational diabetes. And most doctors say, don't worry, after you've given birth, it will get back to normal. Wrong. There's a 60% lifetime risk factor of getting gestational diabetes because you had diabetes during pregnancy. But it also, the child has a significant increased risk of diabetes through their life. Hypertension. 4 times increased death rate in 2022 compared to 2020. This is ridiculous. We're in a modern healthcare society. We should be able to change these numbers. Short and long-term outcomes, increased rate of maternal morbidity, seizures, stroke, kidney injury, increased small for gestational age, and increased preterm birth risk. That is what happens with hypertensive disorders during pregnancy. We need to address those. So together with my colleagues in America, Dr. Leslie Stone, Dr. Michael Stone, and Emily Ryburn, they developed this wonderful program called GrowBaby. And in it, they looked at what could we do to support the mother during pregnancy. And the mission, and we did the study at the University of Las Vegas, the mission was to reverse rising maternal and neonatal adverse outcomes, target populations at greatest risk, reduce medical economic impact, and build resilience. It was very simple, to be honest. We're looking at communication with the mother-to-be. We're looking at very basic nutrition support. We're looking at some other basic markers, the zinc, vitamin D, iron, carnitine, and omega-3, genetics, and then support through that pregnancy. These are the genes that we looked at. It's 44 SNPs in 27 genes. And in it, you can see from how they overlap and they impact. We know this. We know that these genes play a role in pregnancy outcomes. So why don't we employ it? Why isn't every mother given a test not for disease monitoring, but for supporting health and wellness during her pregnancy? We know this, but we don't employ it. All these genes impact in different areas. So VDR, for vitamin D receptors, are, for example, impacting the preterm birth, small for gestational age. It also has, in the child postpartum, increased risk of asthma, increased risk of osteoporosis in life, vitamin D deficiency, and cancers. So if we know that, we can support the mother during pregnancy so that she has a certain vitamin D level. At the end of our study, we saw, and I mimicked this into the UK, data. If we had done a GrowBaby study in the UK population, we would see 4 times fewer incidents of preterm birth. Actually, it's more than that. It's difficult to work out. The UK is 8%. We know that we can come down to about 2%. Small for gestational age would be halved. It would be 10 times less likely of hypertensive disorders, 10 times less likely for diabetes, and 6 times less likely for gestational age. All you do is a genetic test, and there's a QR code there for you to see more information, but all you do is a genetic test on the mother to be early as possible, even better preconception, both in the father and the mother, but obviously if it's only post-pregnancy with the mother is sufficient, and you then help her understand how to carry her child through the 3 trimesters. Calculating this for the country economists, if you employed GrowBaby as a strategy, we suggest that your savings in the United Kingdom would be between 2.8 and 3.4 billion pounds a year. When we think about things like Brexit, and they were saying they're going to save all this money in the NHS, to give to the NHS, etc., they could have just done this. We'd still be, I wouldn't have had to have my Irish passport. So what I find deeply disturbing with the healthcare environment is that we do not employ knowledge quick enough. We do not bring it to the population that would benefit from it. We say, we wait and see, wait and see, wait and see, wait and see. Okay, how are we going to wait and see? We're seeing this invasion of chronic disease. It's going up and up and up. One of those impact factors is preterm birth. So what are the long-term economic impacts? This was a study that looked at 28,000 children who were born from 27 to 31 weeks of age. And the increased annual costs for those 28,000 was £262 million a year. This is after they've got to normal weight. There's a very significant cost, even postpartum at normal weight. Hugh et al. Looked at the hospital admissions from all of these age groups dependent on when they were born. And higher hospital admission costs were incurred in children born extremely preterm and very preterm during the 8th year of life. The 8th year of life, compared with children born at 40 weeks. So children born extremely preterm had the highest 8-year cumulative hospital admission costs at £80,000. So it doesn't just end at birth. The impact is longer. Then we've got Magnum et al. Looked at the costs with a hypothetical cohort, a little complicated, but still the model estimated the total cost of preterm birth to the public sector is £2.9 billion, which is what we saw earlier. This study was found the association between preterm and lower academic performance. We all want our little kids to do fantastically well at school. Every one of us. There's no one that says... And yet these poor little kids that are born preterm perform poorer at school. So studies have shown that maternal and paternal dietary intake in the environment and environmental exposures preconception play an important role in fertility, pregnancy, and offspring outcomes. We add the genetic component into that, we'll be able to help define the pregnancy for that mother, so she won't go through those. Obviously, miscarriage is not a good thing. Hypertension is not a good thing. Gestational diabetes is not a good thing. Early birth, too small for gestational age or too large for gestational age, are bad things for that child. This was the idea at the very beginning, that we use genetics for those mothers, and Dr. Leslie Stone has overseen, I think, something like 6,000 births through their project with very, very, very low levels of preterm. It's under 2%. And we've just got a funding from a big American insurer for 500 women study in North Carolina that begins, I believe, in January or February. And the funding is large, the cohort's quite large, and the mission is the same. Can we reduce the 10% predicted preterm birth rate to 1 or 2% through this relatively simple personalization of the mother's pregnancy through using genetics, basic baseline phenotype data, and then simple nutritional interventions. So I have two requests at the end here. The first is to any researchers. This is great potential. Let's employ it. Let's do better science. Let's bring that to research institutes. Let's bring it into the NHS. Let's bring it into real life science. And that probably should start before pregnancy. We should really understand that we can do a lot pre-pregnancy to support the offspring and the next generation. And if I was looking at 125-year-old me and saying to myself, well, what have you done with the knowledge that you had? I would say, not enough. We don't do enough. We have knowledge, but we don't take it. We don't use it. We leave it on the shelf. And then we go back to, oh, if only I'd known. Well, we do know. We have a lot of data, a lot of information, a lot of simple processes. The cost of this test is about €200. The cost to the government would be less. So we need to encourage politicians. The UK government wanted to reduce it to 6%. They failed. They've gone up. Right? Great. They spent, I don't know how much they've spent on it, but they've gone up. Then, if they'd spent their money with a genetic test for these mothers, they would have reduced it not to 6%, but probably 4%, 2%, or even 1%. In the US, we did that. So my mission in all this is to take complicated science and bring it to the masses in a simplistic form that is really measurable. And my take home on this, or my last point on this today, is that a study was published in Denmark this year, at the end of last year, trying to elucidate the savings to society if all children were born to term. And you cannot believe the numbers. It is billions. In any one class, any one classroom, it's millions of dollars over the course of a lifetime. So if that's not enough incentive, then I don't know what is. We have the ability to change social dynamics by employing simple science. And I go back to Bill Clinton in the year 2000. We have the best map ever produced. Use it. Thank you.